Welcome to JACC This Week, where impactful science meets global insights. I'm Dr. Carolyn Lam, here with Dr. Harlan Krumholz as we go beyond just summaries and discuss why findings matter, what was debated behind the scenes, and how our field should be thinking differently. And this week, we are so excited to be joined by a very special guest. Our friend, associate editor, very, very respected colleague, Dr. Rishi Wadhera. Rishi, welcome.
Thanks so much for having me, Carolyn and Harlan.
You know what? You know why you're here, right? Because for the first time, we have an entire issue focused on JACC Cardiovascular Statistics. I have to ask one of you, please tell me, maybe I'll start with Harlan. Why JACC Stats? What are we doing here?
Well, thanks, Carolyn. It's great to be on with you. It's great to be on with Rishi. It's a distinct pleasure to have him. You know, he really led this with Leslie Curtis, this very special issue that is about accountability, is about informing us, informing our community. Where do we stand? How are we doing? We're in the midst of a remarkable period of breakthroughs. Life sciences are going, full force and breaking, new ground. We've got new therapies, we've got devices. I mean, medicine itself seems to be making breathtaking progress as we go to the meetings every year, every quarter. There's announcements of new trials, and it should be that everywhere we look, we should be living longer and better, and all the cardiovascular health should be getting better. But we're hitting a period where things have stalled a bit. And, a lot of us come from this sort of outcomes research background. And, what's outcomes research? It's really a bunch of people who are focusing their careers on what we think matters most to patients. How long do they live? How well do they live? How well does the system function? To what degree are we achieving a system that's effective, efficient, equitable, patient-centered, timely, and safe? And then as we look out beyond that, to what degree are we helping people to optimize their health and not even get sick in the first place? But in order to do that well, we have to have a real sense of where do we stand? And are we making the kind of progress that we think? And again, what we wanted to do was to say, we think every year we should take stock. We should try to pull together the information that's out there and help our readers in some sort of holistic way understand where do we stand, where have we made progress, where is progress slowed or even reversed, and what is it that we need to redouble our efforts in to try to make progress on behalf of our patients and the larger community and society.
Hi.
And I turned to Rishi and Leslie and I said, I know this sounds crazy, but could we do it for this year? I think I said it, in the early fall, and they were just crazy enough to say, like, I think we can. And so I want to turn it over to Rishi because I'd like him to introduce himself a little bit and maybe tell us, why'd you do it and how did you possibly achieve this in such a short period of time? So Rishi, want to give us some sense of that?
Yeah, no, thanks so much, Harlan and Carolyn. I'm a non-invasive cardiologist at Beth Israel Deaconess Medical Center, and I'm the associate director of the Smith Center for Outcomes Research here. And I'm an outcomes researcher, a policy researcher. So I spend a lot of my time thinking about how we can improve access, affordability, care delivery, quality, and outcomes when it comes to cardiovascular health to all groups in the country. And so, I was very excited when you raised the possibility of JACC putting its own mark on an annual cardiovascular statistics report. And just building off your comments, I think one of our goals was really, in addition to providing a clear-eyed and honest understanding about where we are, where we've made gains, and where we've fallen behind, I think we wanted to do it in a way that was concise, highly visual, and create a report that really prioritized accessibility and usability so that patients, the public, clinicians, policymakers, public health leaders, diverse stakeholders could quickly see where progress is being made and where critical gaps remain. And I think the reason it felt crazy to try to put this together in such a short amount of time, but it was so rewarding and a testament to the entire JACC editorial team and staff and Leslie and Sanket. I think our goal is really that this report, which will be released annually now, informs conversations, sharpens decision-making, and leads to meaningful action that improves cardiovascular health nationally.
Man, I so appreciate what you both gentlemen just said. And I love what you wrote in your foreword, which was, we cannot improve what we do not measure. And This is not about simply producing a report or attracting attention or garnering citations. The purpose is to elicit action. How cool is that? Now, Rishi, you've already started on what we can expect to see in the issue. Could you then maybe point out some of the stats that stood out to you, anything that surprised you, and what action should be elicited? What should we be talking about?
Yeah, no, it's a great question, Carolyn. I think one of the biggest takeaways from the report is that we're seeing reversals across several foundational drivers of cardiovascular health. I think hypertension is a prime example. It really is the silent killer, in my opinion. Nearly one half of US adults now meet criteria for hypertension, and many people are just not even aware they have the condition. And this is one of those conditions that's really treatable. We've made progress in detection, treatment, and control from a therapeutic standpoint, but that progress has stalled over the last decade. One of the other big takeaways was the prevalence of diabetes and its associated complications have continued to rise, particularly among young adults. And I think that's a theme in this report, this sort of burgeoning crisis of cardiovascular health and increase in cardiovascular comorbidities among younger adults. And then we also saw similar patterns amongst people with lower incomes. And then, of course, obesity has reached epidemic levels across nearly every sociodemographic group. And so I think the cardiometabolic risk factor part of this report was really, really striking. And one of the biggest concerns is that the stalling we're seeing, the reversals we're seeing, they're not evenly distributed. They are concentrated among specific populations. Again, younger adults, communities that have historically faced barriers in access to care. And I think that's setting the stage potentially for a tsunami of cardiovascular disease in the decades to come.
Wow. And Harlan, what stood out to you?
First, I want to say that there's some spectacular graphics. I want to highlight Taryn Myers, a member of our team, who really put together these infographics that are just breathtaking. Can really tell a story. But I think that when you look at this, and one of the things that we want to put in bright relief is this execution gap. When you're in cardiology and you're deep in, sometimes you don't really see the big picture. And part of that big picture is that, for example, statin use in secondary prevention is still only about 60%. And we're seeing, like Rishi said, at a time when we've really got remarkable drugs to treat obesity continues to rise inexorably. And we saw AMI mortality improve dramatically, but in younger adults, it's still worrying. The heart failure mortality continues to go up. I mean, again, what we're doing is synthesizing data that has appeared in very many different places, but this is now a one-stop shop. And I think it's time for us to take a step back and say, are we doing the best job possible? Where are we failing? And when we do report things like heart failure mortality going up, by the way, that's on an age-adjusted basis. So that's not just that the population's getting older and you sort of expect that to happen. It's controlling for age, that the mortality is increasing. And, this piece, I think, is intended to kind of catalyze action for us to be able to think, what can we do for individual patients, for local practices? What should we be doing with regard to policy? If we want to see that kind of progress that we saw in cardiovascular disease from the 1960s to like 2010, which was just a remarkable decline year after year in cardiovascular mortality, and we want to see that again, then we need to take stock and figure out what happened, why did we stall, and what are we going to do to fix it?
Oh my goodness. I love that this is like holding up a mirror and really reflecting, as you put, a commitment to accountability grounded in evidence and driven by a belief that numbers tell a story that we can change. And I took the numbers for heart failure to heart, love it. But I have to admit, I'm in Singapore. I'm practicing in Asia. There's a huge population out there. What are we supposed to do with these numbers? Rishi, what does the rest of the world take home from this?
Yeah, no, and I would say we've talked a lot about this. The first annual report really focused on the United States, and we are looking in subsequent reports, annual reports, to expand this to really make it a global snapshot on the state of cardiovascular health. So I think Carolyn, your point is really well taken. A meaningful part of the story, as we called it, is really uniquely American. I think there are many other countries that are grappling with rising obesity and diabetes, but the US sort of stands apart in not a positive way for how consistently those risks translate into worse cardiovascular outcomes and how wide the gaps are by income, race and ethnicity, and geography. And I think as we were talking about this, the JACC team and thinking through it, I think two things were really, really distinctive, in part because the first report was a US focused one. First, the US is world-class at high-tech rescue care, but far less consistent when it comes to prevention and long-term risk factor control at the population level. And second, thinking about the unique American story here, we know that the US has a far more fragmented healthcare system and a weaker social safety net, which is becoming weaker. And now with gaps in insurance coverage, the high and rising cost of prescription drugs, poor access to primary care, and lived environments that make healthy choices very challenging. And so, again, I think there was a lot in the report that reflected some of the challenges that, if you think about cardiovascular health, not in a vacuum, but zoom out and think about rising income inequality that has increased steeply in the United States and all the things that go with that. Where poverty is, cardiometabolic risk factors and cardiovascular disease is higher in the United States. What are the things that go with that? Poor access to care, not living in a neighborhood that allows you to walk, less green space, exposure to dangerous environmental conditions, poor access to healthy, nutritious foods. All of those themes sort of came out of the discussion from this report. But yes, in the next series of JACC Cardiovascular Statistics reports, we are planning to provide a global snapshot for our readers.
Rishi, thanks so much. When you were mentioning those themes, I kept thinking those are globally applicable. So you're so right. Even in the current issue, there's plenty for everybody to take from. But I'm thrilled to know that you're going to be doing it, globally and worldwide. Harlan, you've had so much experience elsewhere in the world. You've always said from the start that JACC is a global journal. So what are your thoughts about that?
Well, first, again, I want to congratulate Rishi and Leslie and Sanket and the team for putting this together. It's V1. It's spectacular, but it's just the first. And we do have aspirations to make it even stronger. The challenge is, again, to continue to make it coherent, digestible, not just throw a bunch of stats into the issue, but actually tell a story. And that's where the art of this is, trying to put together a report that really tells a story. It's, I think, incumbent upon us to think about the world globally. Of course, we have the Global Burden of Disease report that came out in December that did provide that worldwide perspective. Now we got to think about, for this annual report around accountability, to be able to provide some perspective of what's going on. And when I say around the world, it's in our world. It's not like around the world. It's worldwide, not just in the US. And we also have to think about whether there are other things that we want to report in this issue, because we couldn't get everything in. And we sort of had covered in the JACC stats, coronary heart disease and acute myocardial infarction and hypertension and heart failure and peripheral artery disease and stroke. We were sort of covering these different areas, but there are still lots of other areas that we didn't. And so we have a series of brief reports looking at things like out-of-pocket costs and financial burden, looking at spending and mortality, looking at healthcare access and atherosclerotic disease, but also things like diet and exercise and sleep. All these things are really important too. And in future years, it's how can we both maybe expand the focus a little bit to be able to be sure that we're bringing in a lot of areas that are relevant that we might want to be taking into account. And then geographically being able to not just be focused only on one country, but to try to take a more global look at this. So these are all going to be challenges to us because, again, in the end, we don't want to just overwhelm everyone with data and stats. We want to tell a story. So I know, Rishi, this is going to be, how do you think you're going to do that next year?
I don't know. It'll be something that we can brainstorm together. I think we can do it, though.
Yeah. And we'll be looking for readers to give us feedback, too, about what they like this year, what would they like us to do better, and was this a service to them? And so, we hope we can iteratively improve through taking that kind of feedback from our readers and get better over time. Every year should be better than the last.
That's great. And listeners, you heard it. Please write to us, interact with us, tell us what you liked, what you think you want more of, how things can be improved. We're really, really keen to learn. Now, before we round it up, though, just take it home for the current listener, the current clinician, the readers of JACC out there who are going, okay, this is really cool. I'm going to take a look at it. That's a lot of information. What do I need to do that may change my practice even right now? Rishi, could you give us a couple of pointers, and then maybe Harlan?
I think one of the takeaways based on sort of this comorbidity crisis in young adults and what it means in terms of downstream cardiovascular health is screen earlier, of course, appropriately, but screen earlier and close the treatment gap. We have more effective treatments than ever. But when you look across cardiometabolic risk factors, only about half of patients who need them are getting them. So as Harlan said earlier, the gap isn't a knowledge gap, it's an implementation gap. And then I think beyond screening and treatment, I think we need to think systems, not just patients. When the same inequities and disparities are showing up across every cardiovascular risk factor, every condition, that's really not just an individual failure, it's a systems problem. And so I think we as clinicians need to advocate for workflows, policies, community-based interventions that are best for our patients and reach underserved populations.
Wow. Harlan?
I think what's important about this also is that it's not seen as a criticism of the profession. We're stalled for a whole bunch of reasons. And it's not that the doctors aren't smart or caring and the nurses aren't smart and caring, that the whole care teams don't want to do well. There are things that are conspiring against us, and maybe it's the way that the business of medicine has evolved, the shortening of the visits, the fragmentation of the care. We got electronic health records, but it's almost made it more difficult rather than easier for us. And so JACC Stats and the kind of, when we reflect on the lack of progress, it's not a criticism of the profession or any individual doctor. It's saying that we need to get our act together as teams, as a system, as an approach.
I totally agree.
We can all reflect on what's happening on our watch. It's incumbent upon us to each be thinking about our own practices, our own communities, and then our own areas of influence to say, what could we do that would fundamentally improve the level of performance, to be able to elevate the kind of quality of care that people are receiving and giving them the best shot at achieving the kind of health that they seek. And I think if you're looking at these numbers, you're seeing both behavioral and clinical, there are immense opportunities still for us to do better. And of course, that's in partnership with our patients. It's not about imposing on them, but there must be ways that we can somehow break this logjam because, for about the past 15 years, we've been stalled. And that's what this is showing in bright relief. And so as we think about, again, the patients we see individually and in our practices and in areas that we have influence, what would we want to try differently that might make things better? And this report card just says there are a lot of opportunities.
Wow. Another reminder that JACC exists not only to publish science, but to inspire change. Thank you both so much. You've been listening to JACC This Week, bringing impactful science with global insights. Hey, if you liked what you heard, please subscribe, share, email us at jacc@acc.org. See you again next week.